Collapse of lung occurs when the air escapes from the alveoli and they become deflated. Collapse can affect the whole lung, a single lobe, or a segmental component. It is a subtype of atelectasis, which is a more generic term for incomplete expansion. So collapse is not entirely synonymous with atelectasis. When there is collapse of an entire lobe of the lung, it is called lobar collapse. Etiology. Luminal causes are aspirated foreign material, mucus plugging, endobronchial mass, misplaced endotracheal tube. Mural cause include lung cancer and extrinsic cause include compression by adjacent mass. Collapse of lung is an important cause of a white lung on X-ray. When confronted with a white lung, it is important to be thorough in looking for the features suggestive of collapse. Collapse leads to a loss of volume of that part of the lung, and so the normal radiological landmarks will be distorted. To diagnose collapse, look at each of these markings carefully and decide whether they are in correct position. You may need to look at the lateral X-ray as well as the PA. To understand collapse better, we will review the lobes and fissures in short. The left lung is divided into two lobes, upper and lower, by the oblique fissure. The right lung has two fissures, oblique fissure and horizontal fissure, which separate the lung into three lobes, upper, middle and lower. Radiographic features of lobar collapse. There are several classical rules that a lobar collapse follows, such as displacement of a fissure occurs towards the collapsing lobe. A significant amount of volume loss is required to cause airspace opacification. The collapsed lobe is triangular or pyramidal in shape, with the apex pointing to the hilum. Generic markers of volume loss. The direct signs are displacement of fissures, crowding of pulmonary vessels. The indirect signs are elevation of the ipsilateral hemidiaphragm, crowding of the ipsilateral ribs, shift of the mediastinum towards the side of atelectasis, compensatory hyperinflation of normal lobes, hilar displacement towards the collapse, and shifting granuloma sign. Shifting granuloma sign refers to a shift in the location of a parenchymal lesion visible on prior films that may be seen in the presence of atelectasis. For example, this occurs when a calcified granuloma is present in a lung and a significant parenchymal collapse shifts it from one location to another. Now an example of shifting granuloma sign. 4 months earlier, this patient had a right lower lobe mass with right hilar enlargement and multiple rounded pulmonary densities. Now there is right upper lobe collapse with shifting of the previously characterized right lower lobe mass superiorly, increased volume loss compared to prior examination, and associated generalized increased density of the right hemisphere. So here you can compare before and after the collapse. Now some diagnostic clues. Look at the lung fields. The right lung should be larger than the left. If it is not, suspect an area of right-sided collapse. In this X-ray, the right lung is smaller than the left. Look for the horizontal fissure in the right lung. If this is pulled up, it suggests right upper lobe collapse. In this X-ray, the horizontal fissure of the right lung is pulled up. The heart should be in the midline with 1/3 to the right and 2/3 to the left. The heart shadow may be deviated to the side of collapse. In this X-ray, the cardiac shadow is not visualized as it is silhouetting with the opacified hemithorax due to mediastinal shift to the right side. The heart borders should be distinct. If the lung adjacent to the heart is collapsed, then the heart border will appear blurred. If the right heart border is blurred, this indicates right middle lobe collapse, and if the left is blurred, it indicates lingular collapse. This is a case of right middle lobe collapse. X-ray demonstrates some increase in density in the right lower zone medially. The right heart border is somewhat ill-defined. Another diagnostic clue is to look at the diaphragms. The right diaphragm is usually higher than the left. Collapse in the left lung may distort this. In this X-ray, the left diaphragm is higher than the right. The trachea should be central. Collapse of the right or left upper lobe can pull the trachea towards the area of collapse. This is a case of right lung collapse where the trachea pulled to the right side. Radiographic features of right upper lobe collapse. In a frontal view, there is increased density in the upper medial aspect of the right hemithorax, elevation of the horizontal fissure, loss of the normal right medial cardiomediastinal contour, elevation of the right hilum, hyperinflation of the right middle and lower lobe result in increased translucency of the mid and lower parts of the right lung, right juxtaphrenic peak, Caton sign. This is a case of right upper lobe collapse. There is increased density in the upper medial aspect of the right lung. Elevation of the right hilum is seen. There is loss of the normal right medial cardiomediastinal contour. Elevation of the horizontal fissure is noted, and there is slightly increased translucency compared to the left. Juxtaphrenic peak sign is also known as diaphragmatic tenting or Caton sign. It refers to the peaked or tented appearance of hemidiaphragm which can occur in the setting of Lobar collapse. It is caused by retraction of the lower end of diaphragm. It is commonly seen in collapse of the left or right upper lobes, but may also be seen in middle lobe collapse. This chest X-ray demonstrates a large opacity in the right upper zone consistent with collapse of right upper lobe secondary to a hilar mass. The right hemidiaphragm has a peaked or tented appearance which is compatible with juxtaphrenic peak sign. In the previous video, we have learned about the silhouette signs on frontal chest X-rays, and we know that loss of right paratracheal stripe indicates that the pathology is in the right upper lobe. As the silhouette of right paratracheal stripe is lost, the collapse is in the right upper lobe. This is another case of right upper lobe collapse, lateral view. It is harder to identify as the soft tissues of the shoulders usually obscure the upper zones and the collapse is mostly medial. There is wedge-shaped opacification in the upper anterior chest. A common cause of lobar collapse is a hilar mass. When a right hilar mass is combined with collapse of the right upper lobe, the result is an S shape to elevated horizontal fissure. This is known as golden S sign. In this X-ray, there is a right upper zone opacification contiguous with the right hilar mass and loss of the right mediastinal contour. The horizontal fissure is retracted superiorly, elevation of the right hemidiaphragm and rightward mediastinal shift. This case is a classic example of the golden S sign, indicating right upper lobe collapse secondary to obstructing right hilar mass. Now radiographic features of right middle lobe collapse. In the frontal view, there is right mid to lower zone airspace opacification. The normal horizontal fissure is no longer visible and there is obscuration of the right heart border. In the lateral view, collapse appears as a triangular opacity in the anterior aspect of the chest overlying the cardiac shadow with its apex at the right hilum, and the horizontal fissure is displaced inferiorly. This is a case of right middle lobe collapse. Chest X-ray demonstrates some increase in density in the right lower zone medially. The right heart border is somewhat ill-defined, which is shown in blue dashed line. We know that loss of right heart border indicates the pathology is in right middle lobe. As the right heart border is ill-defined, the collapse is in the right middle lobe. Lateral view demonstrates a triangular opacity projecting over the cardiac shadow. This wedge of increased density is the collapsed right middle lobe, which is shown in orange arrows. We know that loss of anterior right hemidiaphragm silhouette indicates right middle lobe pathology, as the opacity is obscuring a part of the anterior right hemidiaphragm. The collapse is in the right middle lobe. Now, radiographic features of right lower lobe collapse. In the frontal view, there is a triangular opacity at the right lower zone, usually medially, with the apex pointing towards the right hilum, obscuration of the medial aspect of the dome of right hemidiaphragm, inferior displacement of the right hilum, preservation of a clear right heart border which is contacted by the right middle lobe, and inferior displacement of the horizontal fissure. This is a case of right lower lobe collapse. The collapsed right lower lobe, which is shown in orange arrows, results in a triangular opacity in the medial part of the right hemithorax. We know that loss of right hemidiaphragm silhouette indicates right lower lobe pathology. The right hemidiaphragmatic outline is lost, so the pathology should be in the right lower lobe. There is a shift of the mediastinum and trachea to the right. In the lateral view, there is an opacity in the posterior part and obliteration of the silhouette of the right hemidiaphragm. The collapsed right lower lobe is shown with orange arrows. Also, the posterior part of the right hemidiaphragmatic outline is lost. The anterior part is partially visible. We know that loss of posterior right hemidiaphragm silhouette indicates right lower lobe pathology. As the silhouette of posterior right hemidiaphragm is lost, the collapse is in the right lower lobe. Now, radiographic features of left upper lobe collapse. In the frontal view, the left upper lobe collapses anteriorly, becoming a thin sheet of tissue opposed to the anterior chest wall and appears as a hazy or veiling opacity extending out from the left hilum and fading out inferiorly. It thus reverses the normal slight increase in radiographic density seen as you move down the lung. This is known as veiling density. The left heart border and the aortic arch are often obscured. The left hilum is drawn upwards, resulting in an almost horizontal course of the left main bronchus and vertical course of the left lower lobe bronchus. This is a chest X-ray showing features of the left upper lobe collapse with loss of volume. There is loss of the normal left cardiomediastinal border. The hazy or veiling opacity is shown here. The left hilum is drawn upwards. And the left hemidiaphragm is elevated. In the lateral view, there is increased retrosternal density, anterior displacement of the oblique fissure and left hilum, and hyperexpanded left lower lobe. Left upper lobe collapse is confirmed in the lateral view. The oblique fissure is displaced anteriorly, which is shown with orange arrows. There is increased retrosternal density. The elevated left hemidiaphragm is seen. Luftsichel sign is seen in some cases of left upper lobe collapse and refers to the frontal chest radiographic appearance due to hyperinflation of the superior segment of the left lower lobe, interposing itself between the mediastinum and the collapsed left upper lobe. In this X-ray, there is hazy opacification of the left hemithorax with obscuration of the superior mediastinum and left cardiac border. There is well definition of the lateral aspect of the aortic arch by air, which indicates Luftsichel sign. Now, radiographic features of left lower lobe collapse. In the frontal view, there is triangular opacity in the posterior medial aspect of the left lung, which is known as retrocardiac sail sign. Left lower zone opacification, usually medially, with the apex pointing towards the left hilum. Edge of the collapsed lung may create a double cardiac contour. Inferior displacement of the left hilum. Flat waist sign. Flattening of the left heart border. Obscuration of the left hemidiaphragm and descending aorta. Preservation of a clear left heart border which is contacted by the lingular segments of the left upper lobe. Inferior displacement of the oblique fissure. This is a chest X-ray of left lower lobe collapse. There is a triangular density behind the heart. This retrocardiac density is shaped like a sail, the sail sign. The left hilum is inferiorly displaced. There is volume loss in the left hemithorax. This is another X-ray of left lower lobe collapse. A double contour to the left edge of the heart is visible. In addition, there is loss of the left hemidiaphragm and descending aortic outline. In the lateral view, there is triangular opacification in the lower posterior chest. Left hemidiaphragm is obscured posteriorly and the lower thoracic vertebrae appear denser than normal. They are usually more radiolucent than the upper vertebrae. Oblique fissure displaced posterior inferiorly but may be invisible with a severe collapse of the left lower lobe. Inferior displacement of the left hilum. Findings of this lateral X-ray are opacity of the left lower zone, posterior deviation of the oblique fissure, and obliteration of the normal outline of the left hemidiaphragm. Here, opacity of the left lower zone causing thoracic vertebrae appear denser than normal. Posterior deviation of the oblique fissure is shown with orange arrows, and loss of the left hemidiaphragm is shown with blue dashed lines.